Thank you so much for joining our monthly webinars. This one is going to be really packed with a lot of information of a lot of news that's going on in the 340B program. And let's get started so that we can go through everything. Before I start, I do want to introduce myself to, maybe there's those of you that are new and this is your first time joining. My name is Anthony Velasquez. I and the Chief Product Officer here at PharmaForce, a third-party administrator and pharmacy solutions provider in the healthcare pharmacy space. Um, and I'm just really excited to be with you today, sharing everything that's going on in the 340B program. Um, as you all know, we do this once a month. I try to stick to about 30 to 45 minutes, just because I want to make sure that this is a good use of your time and that we're providing valuable insights and information on the 340B program. Um, so I hope you guys are enjoying this format, a format where we are discussing kind of like the newest headlines and updates as it relates to the 340B program. And there are many of them. And this webinar, I hope you see that, yeah, it's jam-packed with a lot of stuff that's going on. So let's go ahead and get started. Before I get started, I want to go ahead and share with you a quick disclosure. This disclosure is that the information in this presentation, including any analysis or opinions, represent only the personal views of the presenter. These perspectives do not necessarily align with the official stance of PharmaForce or its affiliates. This content is intended for informational purposes only and should not be considered legal, financial, or professional advice. All right. So again, this is, me being over a decade involved in 340B, working for providers, working for a third-party administrator, working at grantees, working at large hospitals, and really just desiring to take all the information and just translate it in a way that it makes sense. And it helps you be informed of what's going on in the 340B program. Some of the stuff is tricky, some of the stuff is political in many ways. So I'm going to try my best just to present the facts and do not take anything that I say as legal opinion or anything that you should do differently in your 340B program. Okay, so where do we start? So I'm going to cover about six major subjects. There are these executive orders that the current President Trump administration have signed that have implications to participants in the 340B program. A lot of it is unknown. Some of it we have some insight of what it could be. So I'm going to cover the April executive order, the May executive order. I'm going to talk about the possible oversight change to 340B. This is not new. This is a rumor that had been going on for a while, but there's been some new insight into what that could be. We're going to talk about this new reconciliation bill that is currently in Congress. My presentation is basically outdated already, and I just and I've been working on the content for the last couple of days, so that's how quickly some of the stuff is moving. We'll talk about a big news on the rebate model, and then what changes may come to 340B that you need to be prepared for and aware, so that you can make the proper changes operationally and inform your leadership and your team of the impact. So let's go ahead and get started. So, all right, so here we are with executive orders. These executive orders, this one that I'm going to share on lowering prescription prices, is very similar to the executive order that we saw in the first term of the Trump administration. So those of you that are not aware of that, what I'm going to do is just break down for you kind of like what the executive order says and does, and then go into what the implications are for your program. All right, so there were five different aspects or five different, let's say key components of the executive order. The executive order is online, so if you go to the White House website, they have the actual executive order that the administration signed, and it's basically targeting prescription drug affordability. So this is not the big kind of controversial one that was recently announced that promises to reduce pharmaceuticals by 60, 70, 80%. That's not that one. That's not that one. I will get to that one in a second. There was another one that was maybe a little bit more under the radar on April 15th that was especially targeting Medicare patients and targeting insulin and epinephrine prescriptions. So So here are the components. So first, it was expanding on Medicare's ability to negotiate drug prices. All right, if you're in a hospital, I remember being in a hospital when this happened. I was still working at a large dish hospital, and when this happened, that you had to add indicators now to drugs administered in your infusion settings. And the indicators were sent out. You're trying to work with the billing department to try to figure out how to add these indicators. It was actually pretty chaotic at the time, where basically you got paid about 28%, if I remember correctly, less than you would have originally, and you almost got like an acquisition cost type of reimbursement for those drugs. If you work in the 340B program, the oncology infusion centers and the 340B program is usually a big driver of savings for 340B covered entities that are part of a dish entity or any type of hospital entity type that's eligible. And this lasted for years. So I'm going back and revisiting history here, but if you all remember this, if you work at a hospital, this lasted a while, and there were many lawsuits. I mean, similar to the manufacturer restriction stuff, where I think I saw a number that there are 90 plus lawsuits, if I'm not mistaken. The number might be even higher, related to some sort of manufacturer restriction, whether it's the government versus a manufacturer, et cetera. So there is a ton of lawsuits going on, and that was the same thing with this. Ultimately, this went to the Supreme Court, and it got struck down, and Medicare had to repay the money that they had taken. So you have to try to unwind that, and it was just a mess. It was a big, big mess. It was operationally very time consuming for many entities. Operation very time consuming for many entities to try to recoup the money, and Medicare was told they had to come up with a process and all that, so it was very, very complicated. So who knows what's going to happen now? But if that is tried, that has been tried before. And it failed, through the courts. So I think you can expect a similar result, but you know, we have not seen how Medicare or CMS plans to implement something like this at the moment. So, adjusting Medicare payments to align with hospital acquisition costs, again, they're kind of tied together in a way that the government is expecting a reduction to the Medicare program. So this doesn't necessarily translate to the patient. It translates to the Medicare program and the amount of money that it has to pay hospitals for services provided to Medicare recipients. So you can make the case that maybe some of that would be, in the pockets of the Medicare patients with a lot of different components of the Medicare program, but in general, it is designed to help the Medicare program reduce the amount of the spend that it spends on prescriptions. It creates a standardized payment for cancer treatments across different settings. So, this sounds like it's more related to, the again, targeting the drugs again, and specifically in the oncology world of things, which is where most of the big dollar prescriptions are at. I have not seen further details on what that means and what that payment program means. It's a very new executive order, and usually what happens is an executive order is written, it's published, it's signed, and then it goes to the agency that is in charge of executing on that executive order, and then they put out, whether it is a some sort of rule change or something like that. So the other one that is familiar, if you are a health center, so if you are a health center and you are on this webinar, this will be familiar to you, but there were the executive order calls out insulin, and basically an executive order that insulin needs to be sold for 3 cents and epinephrine for $15. So that is going to heavily impact the health center. So if you are a health center, the interesting thing about this piece in the executive order is that a lot of this is happening already. So this seems like it's coming out of the administration as if it's not something that is the reality of being a grantee and being a 340B grantee. It is. I know some of my best memories is working at a health center in the North Philadelphia area in Pennsylvania on the East Coast, and having programs where we were able to provide patients with, a self-pay scale and provide medications, at a $10, $15, $20 a month, and sometimes even for a 90-day supply. That was possible because of the 340B program. That was a very rewarding time for me personally to be part of that. And I was the manager that led that area, and we would do this, normally, and actually part of the health centers are supposed to have a self-pay scale, program, and that's overseen by HHS. So, providers, from what I have seen, are not, supportive of this, but I think it's more because there's an assumption that this is not happening, that these drugs are not going to, uninsured patients, underinsured patients at a discount, and in many, many, many cases, they are. So, there will be more to come on that particular process and how that will be enforced by HHS. Um, this one is very interesting to me because this is in both EOs, and this is supporting of drug importation by states and improving Medicaid purchasing power. That is an interesting one. I don't know what necessarily how that translates operationally. We have seen in the healthcare space a increase of utilizing pharmacies in Canada, for example. That's one example that I'm very familiar with of. Um, Health systems that are self-insured, that have a pharmacy for employees and things like that, that is shipping from Canada. And this executive order seems to sort of, further that with Medicaid, and it gets a little bit interesting because you don't really know, and I haven't seen anything that translates this into what does that look like operationally? Like, does that mean that Medicaid through its own PBMs and through its own pharmacy network are now going to be able to provide patients with medications, from other, the other EO says other developed nations, but let's say from, other places. And that's, I think, what it means. And the implication of some of this to the 340B program is not yet known, and I don't think we're going to know for a while. And who knows if some of these things, actually end up being operational, anytime soon. So we will see. We will see. Some of these things are very difficult to decipher whether it has immediate impact or, some sort of impact in the future. Um, the last one was promoting the use of generic and biosimilars and increasing transparency for PBMs. This is the PBM conversation. It's so interesting to me because there is language in Congress for PBM regulation that failed in December. There is language in this executive order about PBM transparency. There's language in the other executive order related to the PBMs. There's been announcements by the new administration and CMS and the other agencies about PBMs and being the middlemen and making the entire, prescription and drug supply chain a lot more expensive than it needs to be. But until you have true legislation, there is no way to truly combat this, in my opinion. So we will see what happens with that, but I doubt that that's going to lead. There are states that are now proposing bills to basically changed the way that PBMs function. There was a state that passed a bill that basically restricted a PBM from having their own pharmacy, their own specialty, and forcing patients to go to their own specialty. Will that hold up at a state level? We don't know, and a lot of that is yet to be seen. But there's definitely is the target on the PBM, itself, and you know from Congress, from states, from the administration, and many other places, because in general, PBMs are known in the industry. I'm just stating the fact, not a personal opinion, I hope, but PBMs are known in the industry for being, the middlemen that ends up taking a lot of money out of the pockets of the patients, if you will, and the employer rebates and things like that in many different ways that are very complicated to explain, on this call. So I hope that makes sense. This is the first executive order that is related to prescription prices. Okay, so I hope that all makes sense. Um, so what does that mean for covered entities? So I share a little bit of the impact. So, these aim to increase, patient affordability. The thing is that sometimes you can have a policy that aims to do something, but it doesn't quite do what it's aimed to do. So what this means for hospitals is potential Medicare payment reductions again and having to deal through, with all of that. And who knows if there's another way that HHS is going to figure out a way to do this, to implement it, knowing that it failed at the Supreme Court in the first Trump administration, that there's some other clever way that they could do and achieve actual Medicare payment reductions to hospitals, which is unfortunate that we are in a conversation where providers are the ones sort of being targeted through this, at the same time that our rural health hospitals and many health systems in the country are forced to merge because of how expensive it is to run a hospital. So, that remains to be seen, but that could be a direct implication of this executive order. The next one is for health centers to pass on savings for insulin and epinephrine to low-income patients, which they do already, but we don't know what sort of different operational burdens and things like that that would impact. I know for a health center, if you work at a health center, passing on the insulin to a patient for 3 cents means that there are other fees. There could be fees with your third-party administrator. There could be fees with the if you use a PBM or a cash card or something like that related to that. There could be fees to set up, different accounts and different workflows to accommodate that for your cash card paying patients. So there's implications there at health centers. I think we'll receive guidance on and how to implement that. And that one was reversed. That was reversed by the previous administration, ultimately. But given that this executive order was done, I think so soon in the administration, I think that was most likely to really come to fruition. There's a strong pushback from healthcare providers. Again, many health centers have said, look, we want to work with the administration. We want to make sure that the administration understands the 340B program is vital to offering, hundreds of thousands, if not millions of people, prescriptions at a lower cost. And I can personally myself, like many of you on this call, can testify that that is true and that happens every single day. So, and that's why we're in this industry. Many of us are in 340B because of, we believe in that the mission of the program is to help healthcare providers and patients get access to um, lower prescriptions and savings. So, all right, now this was the big one. This executive order on the most favored nation pricing is, let's just say, controversial. Again, I'm going to try to state the facts, not my opinion on how I feel or support or not support of this, because I don't think that's helpful to anybody. But I'm going to kind of take the executive order is actually a little bit lengthy. I think it's like 2 or 3 pages if you read it. But I want to try to break it down and point out the 4 key points that I think are important for you to take away. This is one that really has everyone scratching their heads of, how does this even work? Like, how do you even take a massive, several billion-dollar industry, and try to change it via an executive order. Because that's essentially what the executive orders aim to do. So point number one is the executive orders aim to say that the United States should have access to the lowest global drug prices, and the administration will act to end overcharging. The administration has basically said, look, why are we paying, let's say, $6,000 for a product here? I think the example that they actually share was, why is Ozempic or Wegovy $1,200 here in the United States, but it's, less than a couple $100 in the UK or in Canada or in other places, right? Why is that? And, basically it goes into some other examples of like the United States is basically funding the pharmaceutical industry so that they can then sell the drugs at a discount in other places and not give the United States the lowest price, even though the United States is funding the research and development and a lot of that stuff. Again, I'm not going to get into the details of what is, what's true, what's not, or any of that. Then it says that the U.S. Trade and Commerce officials, point number two, will be given 30 days to provide global price targets to drug companies. We have not seen that yet. I have no idea what that looks like. I don't know how that will be implemented. I don't know how that has any chance of being implemented overnight, or in any significant way that will completely, let's say, overhaul the drug supply chain. I just don't. I honestly don't know, and maybe I'm not an expert on drug policy. I would love to get an expert on drug policy, and I'll actually try to do that. Get an expert on drug policy to join us, but. I don't know how that's going to happen. That sounds like a very, very complex task. Point number three, the Secretary of HHS is tasked with facilitating a direct-to-consumer purchasing programs, ensuring that they sell products to patients at the most favored nation price. This is the most interesting to me, that I'm really curious to see what does this look like operationally, because we live in a system where the way that a consumer gets medications is through having insurance or paying cash and going to a network of pharmacies, whether it is the pharmacy, at your supermarket or on the corner of the busy street, or online, through some other online provider or mail order pharmacy or something like that. So I don't know what HHS could do to, I guess there is a direct to consumer already, kind of, through some of the manufacturers that sell that can ship drugs directly to patients. So I guess there is something there, but if you have insurance, like, are you now going to go directly to the manufacturer? I don't know. That one is very, very interesting to me of what that, if you're on four medications and each of them are a different manufacturer, do you have to go to each manufacturer to get all your medication? I don't know what that is going to look like, to be completely honest. And I don't think, and I haven't seen anything that anyone does yet. So HHS, must have a way of doing this at some scale. I don't know how you do this at a large scale, but that is what the executive order states. Number four, the secretary will certify safe, cost-reducing drug imports. Again, so as I mentioned, here's a second time that drug imports are mentioned, as it relates to executive orders of bringing medications from other countries, developed nations, to the United States to basically reduce the cost that the United States pay for medications and prescriptions. So I am personally, just as a healthcare, I have a master's degree in healthcare policy. I got an undergraduate in healthcare policy and administration. Like this stuff, I'm really fascinated by this stuff because it's really interesting to see how policy becomes operations, and how a policy can operationally be implemented. And these are head scratchers. I just don't know, and I don't think anyone's able to tell us at this point how this will impact 340B covered entities, but it may have some impact. So I'm not saying it will never, but it's too soon to tell. So I hope you guys are okay with that. But that's just me being. I'm not trying to make stuff up. I really don't know. So here's a quick comparison between the two executive orders. So one is to reduce cost of Medicare primarily, I would say, and kind of get like, hey, we're also giving insulin at a low price. The other one, the May 12th, is more of, targeting, making it so the US has access to the lowest global rates, the most favored nation. That's where that comes from. Like, hey, if manufacturer X is selling a drug for $100 in Canada or the UK or somewhere in Europe, the United States should be able to buy that for $100. You know, I mean, I don't know how that happens, but that would impact all patients essentially, where the transparency in Medicare reform is probably mostly Medicare, Medicaid. Um, Medicare pricing negotiation are the key actions, and then global price matching enforced by HHS, which again, I don't know how HHS even does that. I think the expected results are a little bit high because we haven't seen how this would be implemented. So we will see. What I would say, and I'll end on this, is unfortunately what this means is that it doesn't sound like there is federal legislation that is likely. When things like this are being done via executive order, it doesn't sound like there's federal legislation that will be done to target this stuff. However you feel, but I would say from a 340B perspective, it doesn't sound like there's anything, you know, anything in the works from that. All right, shifting gears from the executive orders to the 340 program oversight change. And why do I say this? I say this because many of you have heard the rumors that the 340B program, as part, if you remember back maybe 4 months ago, 5 months ago, there was a rumor that came out that as part of the DOGE, the Department of Government Efficiency, that there was going to be a shakeup in HHS. And that kind of was, was killed. And then later it came out another rumor that the 340B program will be moved under CMS. All right. So here's what we know so far. Here's what we know so far, and it's not necessarily much, but in the president's FY 2026 budget plan, there is essentially a cut of $33 billion in HHS funding that is being proposed. Both HRSA and CMS face significant cuts of 1.7 billion and 674 million. So I don't know what that translates to, but I think if those cuts are if those cuts go through and those cuts happen, operationally, does that mean that the 340B program doesn't have the right oversight, or that funding for the 340B oversight, is not? I don't think so. But those are some of the implications that we're yet to know. There's been suggestion that HRSA is going to be merged with other agencies as well within HHS, and in an attempt to streamline a lot of the different agencies within the Health and Human Services. Um, no specific mentions of 340B were outlined in the budget itself, because again, what we have is leaked documents directly from the Health and Human Services about this potential oversight change of 340B moving under CMS. Remember that CMS, and the reason why this is important is the Centers for Medicare and Medicaid is the one that is charged to implement the Inflation Reduction Act, and is the one that now, through this new executive order, is responsible for implementing this ability for Medicare to negotiate pricing. So if CMS now has, the executive orders to implement, CMS has the Inflation Reduction Act pricing negotiations to implement, and the 340B program under its, purview, if you will. That could mean that there's now more attention to the 340B program from CMS, and more power to do things under CMS than what HRSA and the Office of Pharmacy Affairs has, and that's sort of the kind of concern for providers right now. Now, HHS Secretary Kennedy, Robert F. Kennedy Jr., had a congressional hearing, and the news was this is the first time that he has publicly talked about 340B. There were reports a couple of months ago that he met with several hospital executives, but this was kind of like the first time that there were comments related to 340B, and there were very mixed reviews. So I don't know if you all saw this, but he acknowledged that the 340B program had rapid growth. And the way he kind of said it, I saw the clip, and the way he kind of said it was like the 340B program is a problem and has basically grown a lot. But we understand that it's important, and we don't have any other alternative to touch it. So there's mixed reviews of, hey, what does that mean? Is that understanding correctly that the 340B program has really, ballooned out of control, and that the program right now is supporting, in many, 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 many cases, hospitals remaining open. And if the 340B program goes away, hospitals, health centers, and other providers will literally have to shut their doors. but at the same time, they stress that there's no other plans. There's no other, we have not heard any other type of healthcare legislation or any other, you know, government federal changes that discuss 340B program, the 340B program itself. A lot of the stuff that was being worked in the Senate, which I've been doing these webinars for a really long time. A lot of that stuff I've been discussing and talking about that I was very hopeful that there will be actual 340B legislation, the sustained 340B Act I spent many, many months talking about, and I don't see that at all happening right now with the sort of fight that is currently in Congress over the current reconciliation plan, especially as it relates to the debt and things like that. So these are very interesting comments where we get to hear from the secretary himself. In related news to that, um, and tying in everything about 340B program might move, under CMS and those sort of things. There was a big breaking news on the legal case on the rebate model. So here's what happened. On May 15th, a federal judge upheld HHS authority to demand pre-approval for 340B rebate models. So huge win. If you are a 340B provider, this is a huge, huge win, you know, mostly. All right. So it's not a complete win, but it's a huge win because it means that HHS now has authority to pre-approve these rebate models, which HHS has expressed concern and have rejected these models straight out. So that is great news. As you all know, I did a webinar on that, on the potential of a 340B rebate model and what that means for 340B. So this is just recent, hot off the press. It happened and it's been kind of making its waves and tons of articles are being written about it. So there were lawsuits from several drug manufacturers. They were all rejected. There was a partial win in one where basically the court said HHS didn't sufficiently explain, its rejection of their proposal. But again, HHS can request a pre-approval. In other words, the manufacturer have to come to HHS and says, we want to change the way that we're delivering the product to covered entities, and HHS has the power, which is point number 4. HHS retains the power to regulate price reduction implementation under the 340B statute. So this is huge. It is still kind of pending what HHS is going to do, but the historical indication that we saw in late 2024 is that HHS has publicly rejected and even has gone as far as saying, hey, if you move forward with this, we may remove you from Medicaid and other government programs to drug manufacturers. So this is a huge, huge win for 340B providers and for a fight against this 340B rebate model, which in my opinion, I think would have very devastating impact to the 340B program in terms of operational execution of it, and sort of opens a door to manufacturers determining their own patient eligibility logic and things like that. So yeah, so that's that. The other thing that's touching 340B right now that's in the news. So we cover the executive orders that could have an impact on the 340B program. We cover the rumors of changes to the 340B agency and who has oversight over that. We cover the rebate models and that big win for healthcare providers. The other thing right now is this reconciliation budget. This sort of huge bill that's now in Congress and is being debated. And if you say something now, 2 hours later, you're out of date because it's changing that fast. So this bill essentially, passed the House Energy and Commerce Committee. And essentially now it's being debated on what's in the bill. There's all sorts of discussions about things that are in the bill. The most controversial piece of legislation in that bill is cuts to Medicaid, which impact all of you. So if you are on this call and you're a hospital, you're a health center, you are another type of 340B provider, this may impact you, your program, and your patient. So there are a lot of tax cuts in this bill. In order to pay for those tax cuts, there looks like there's proposed changes to Medicaid to significantly cut Medicaid. Um, the sort of the big punchline here is that there are estimates that if this bill passes, Medicaid recipients between 8 million to 14 million on the high side, Medicaid recipients could lose coverage. Um, if you are a 340B provider, like many of you are, that are serving a lot of Medicaid patients, then that could have significant impact on your 340B program, on your savings, because it would increase the number of patients that will now be uninsured and underinsured. So there are conditions that are being added in order to get Medicaid, work requirements, and other things that are being added to the Medicaid program through this reconciliation budget that have indirect impact, I would say. I guess you could say direct impact, but what I mean by it is just is there's going to be many potential patients that lose insurance that then will turn into uninsured patients for health centers and hospitals and emergency rooms, and in my opinion, further the need for the 340B program to cover those gaps. So there's PBM reforms. Again, I told you you're going to find PBM reforms in everything that comes out of anyone in Congress or the administration right now. So all eyes on the PBMs, but I don't know if anyone's going to be able to actually, pass legislation for true PBM reforms. We will see. We will see. There was in one of the versions of this bill, there was embedded a 340B reporting requirement. So a need for 340B entities to report to the federal government its savings, how it's using its savings, and things like that. The language is not finalized on that, but that is, one of the things that's embedded in this really large bill. So there's strong opposition to Medicaid on both sides. There are strong oppositions to reduce Medicaid coverage. Primarily, I would say Democrats are arguing for, hey, this is a tragedy. The Republicans have a mixed review on this, but everything's being tied to the debt right now, and that's kind of the conversation. So. Interesting stuff. Very, very interesting stuff. All right, so let's wrap it up. So let's give you a summary. So here's what you're dealing with as a 340B covered entity, and if you're in this space. You're dealing with number one, more reporting requirements, not only at the state level, but embedded in this reconciliation budget bill, which could pass in the next couple of weeks. So what does that mean for you? This stronger transparency standard is not a phrase to say that 340B entities should be more transparent. That is what the proponents of this are saying, is that this submitting annual reports showing 340B funds and benefits to patients is something that should be required for every entity to do. Some states have passed this. I want to say Indiana, Michigan, and some others, or Minnesota, have passed some sort of reporting requirements. A potential oversight shift is another thing of, hey, if the 340B program moves from HRSA to CMS, we know HRSA's stance on many things. We don't really know CMS stance on really thing. What that could mean for 340B. There's cuts to those departments as well. So what that means for 340B, we don't know. It could turn into multiple different scenarios, but we don't know yet. The financial impact from the executive orders is number three. So as a covered entity, you're facing these financial impact for covered for based on executive orders. If you're a hospital, the threat of a reduction in Medicare payments. If you are a health center, you have to now add potential additional operations for supporting selling insulin and epinephrine at a discount to patients. The Medicaid changes via this reconciliation budget again could impact eight on the low side. Some estimates are saying 14 million individuals that could lose Medicaid coverage if this passes as is. The manufacturer restriction, now that federal legislation does not seem likely, unfortunately, in the near future. The continued limits on 340B discounts through contract pharmacy is just a challenge that entities continue to face. And sort of it's part of the new world of being in 340B. HHS decision on the rebate model. So number six, even though HHS won, they only won on pre-approving a rebate model, but they have not finalized or provided guidance on how manufacturers are going to implement the drugs that are part of the Inflation Reduction Act. There's some things that need to be clarified there. So, in summary, all of these leads to financial strain on you, the provider, and all of these restrictions together for sure will cause some safety net hospitals to consider reducing certain services and certain things that will not be possible as providers continue to be, picked on for reduction of savings and the 340B program and, lowering reimbursements and all these other things. So yeah, so I don't mean to I don't mean or want to sound doom and gloom, but if you're in 340B and you're a rural health provider, you're a hospital, you're a grantee, these are the realities that you're facing on an everyday basis. And hopefully this presentation helps you feel a little bit more informed about those things. And that is it. That is it. We're going to be at the 340B grantees in Kansas City. We're obviously going to be at the 340B Coalition Summer Conference. I don't have the details on that just yet, but I can't believe that's right around the corner, but it is. These are ways you can get in touch with us. You can follow us, etc. And I hope that this format is really informational. I'd love to hear your feedback. At the end of this, you're going to get a survey kind of asking, hey, what do you think about the content? What do you think about the information I shared? That's really important to us. If you could fill that out just to let us know that we're sharing the right content. We go back and forth as a team of, hey, should we be doing like how to prepare for a HRSA audit? I just feel like there's so many people doing that. There's a whole host of podcasts and other webinars that are doing audits and how to operationalize, these things. And I don't think those things are bad. I want to do some of those things, but I feel there's a lot of value in sharing kind of the macro level implications of policy and lawsuits and things that are going on in the market. And I want to continue to do that. So please let me know if you find that helpful. Let me know if that's something that you want to continue. I see some of you dropping, but I do want to say that I am available for a Q&A. So if you want to put any questions in the chat, if you want to put, if you want to jump on here and say, hey, I want to ask you a question or talk about it, then I'm available to do that as well. So sometimes we get a ton of questions, sometimes we don't get many questions, but just wanted to share that I'm available to do that for a few minutes. Is that something you're interested in? Yes, this will be posted to our YouTube channel in the next 24 to 48 hours. And you can go right through our website to see that and access that. So, all right, cool. Yeah, thank you. Thank you, Donna. Thank you, June. Appreciate the nice words. All right, so I'm gonna go once. If there's no questions, then we are done. I'm giving you your time back. So once, twice, three times. That is it. All right, thank you so much. Have a great day. Thank you for joining. Thank you to those of you that come every single month. We really, really appreciate it. And I hope that you find this very, very helpful. All right, thank you all. Bye.